All right, I think we can go ahead and get started. For a little housekeeping, try and make sure that your own microphone is on mute. I will try and help with that in case anything comes up. But we're very excited to bring you today the Teaching Anti-Racism Through Simulation virtual mentor panel. This is the second in a series that we're planning throughout the year with the Simulation Academy through SAEM. And we're lucky that they have provided support for this gathering for some very excellent panelists who have volunteered their time to be here with us. And in this challenging time that we're able to meet together in this setting. And I encourage you, if you're comfortable, to be able to turn on your video and participate in the discussion. We can field questions primarily from the chat. I will be monitoring that. And then we'll have a couple of minutes at the end to include any questions or comments that anybody wants to bring up to round out the discussion. We'll start out with an introduction from each of the panelists, and then I have kind of a series of questions that are a little bit structured, but we certainly have flexibility to address the issues that each of us bring to ask about. I'd like to remind everyone that we're all coming from different backgrounds, different levels of understanding of all of the topics involved in diversity, inclusion, anti-racism, and we are here to learn. So we're here, just like we always say before we started simulation, to do our best. But some of us might misstep and some of us might misspeak, and please be kind to each other because we're all here doing our best. So thank you. And by way of introduction, I'm Sarah Hawk, and I am part of the Faculty Development Committee for the Simulation Academy. So that's where this is coming to you from. We're happy to have the Academy of Diversity and Inclusion in Emergency Medicine co-host this with us today. So we'll go ahead and perhaps Dr. Nadir, if you could start with an introduction, just to highlight your current role, any educational initiatives that are related to this that you might be able to share with us as we discuss today, and then we'll kind of go through our list of panelists.
Absolutely. Thank you, Sarah. So I'm Nuran Nadir. I'm the current president of the Sim Academy, or incoming president of the Sim Academy. And my interest in using Sim for purposes of diversity and inclusion initiatives has been long-standing. And involvement has been primarily at University of Illinois Peoria, which was my prior, job, where we essentially had figured out a way to do SIMs using standardized patients. And what we noticed was it was a considerable difference in the approach to our standardized patients coming from different backgrounds. And that's really where the interest took off. And over the years, I've talked about this on a national scale at both CORD as well as at SAM. And I think I'm really excited to be a part of this panel to really foster a discussion, because SIM has been around for a long time, and its role in the has been pretty established for difficult communications. And some of the things that we talk about actually have directly to do with that sort of a background. So I'm really excited to be here, and pardon me if I look like I'm a little tired. I was overnight. So that's pretty much me.
Anybody that'd like to go next? Maybe Dr. Baxter.
Okay. Hi, everyone. My name is Annika Baxter. I am on the executive board with ADIEM. Actually, this is my third year right now on their board, so love them. It's always fun. And then I've also served as co-chair for Emory Emergency Department's Diversity and Inclusion Committee for roughly 6 years or so now. Along with the other panelists, I've been on a past SAEM discussion for how to use SIM to teach inclusivity concepts and difficult conversations. And I'm currently working with a number of the people on the panel as well to sort of take that one step further and work on using simulation for anti-racist, anti-ism concepts.
Maybe we can hear from Dr. Okubanjo next.
Sorry, just unmuting. Hi, I'm Oyen Okubanjo, go by Oyen. I am 2 years past being, maybe a year now past being Sarah's Fellow, where I completed my simulation fellowship. Right now, my current role is I am the resident director of social simulation and simulation projects at Advocate Christ Hospital. I am also part of the education cohort and the education lead for our diversity, equity, and inclusion committee at Advocate Christ Hospital. My background actually comes in all things diversity and inclusion. That is my passion, and I happen to also love STEM. So figuring out a way to marry those two things and teach things that people are very uncomfortable talking about, but I am very comfortable talking about, and I find a lot of fun in talking about those things and really pushing my residents and other clinicians to talk about things that make them uncomfortable. And part of that is actually creating this new project with one of my current residents that we just got IRB approved for, where it is a social simulation, which I can go into details further, but it's how we marry simulation together and social inequities. Because as much as people are comfortable talking about it, you don't really understand it until you experience it. And trying to use simulation to force your residents as well as your attendants to become comfortable in what that experience is that other people have day to day, to create more empathy for your patients. It's really truly the way that we can use simulation in another level. So that is my passion. That is what I do. And I look forward to just being a part of this panel. I'm super excited.
Thank you so much. Dr. Haber, can you go next?
Thank you, Sarah, for putting this together and including me today. I'm Jordana Haber, and I'm core faculty at UNLV REM program there in Las Vegas. And I have a background in medical education. I did a 2-year fellowship in medical education where my focus was on reflections and a narrative practice, basically drawing connections where the procedural domain meets that cognitive and affective domain. And one of my passions, I think, is getting to those uncomfortable conversations. So this just fits really well into that topic of where are our challenges in caring for our patients. So this is really what I'm passionate about, and looking forward to learning more as well on how to connect SIM with some of those concepts.
Thank you so much. And Dr. Bradby?
Hi, everybody. My name is Cassandra Bradby. I'm the Residency Program Director at East Carolina University Invited Medical Center in Greenville, North Carolina. I also have the pleasure of being the Vice Chair of Diversity and Inclusion for the department and the former Chair of the Vice Chairs of Diversity and Inclusion for the Brody School of Medicine here at ECU. So prior to being the Program Director, a lot of what I did was diversity related in the medical school. Simulation has always been something that I've been interested in, particularly in terms of education with our residents. And so like some of the previous speakers have said, marrying the two together has always been something that I'm interested in doing. And it's something you don't see very often.
And finally, Dr. Falk.
Thank you. Thanks for putting this together, Sarah, and hi, everyone. I'm Mike Falk. I'm the current president for the SIM Academy at SAEM. And like many of the people on this panel, I am. We was part of the lead to put together a panel at SAEM 2 years ago now on the idea of using simulation to discuss diversity and issues of inclusivity in emergency medicine. And I'm working with Annika and Naran and some others. We're trying to create now a curriculum exactly around these topics that will hopefully be ready to go in a year or so. So welcome. Thanks for having me.
Our last panelist to introduce is Dr. Dobias.
Thanks, Sarah, for putting this together. Thank you, everyone who came today. It's great to see such a turnout. Dan Egan, so nice to see you on the Zoom. That's awesome. So I'm at the Brigham and Women's Hospital. I direct the internal programs at Stratus. I'm a longtime educator and simulationist. I met Sarah back in the day when she was applying for fellowships, and she's amazing. So lovely to see her progress. So quickly about my background, long history in diversity and inclusion, gender issues. I was on my previous life was at the University of Illinois, and I co-chaired our College of Medicine Diversity and Inclusion strategic planning committee, and I was co-chair of the faculty advancement, academic advancement committee that was responsible for promoting URIM and women in leadership roles. And why I'm here today and why I thought it was important to come together, I'm also very interested in microaggressions and their role in medicine. And so we just put forward a grant and are working on a grant on mitigating these microaggressions in medicine. First of all, we're studying the impact it has, and it's residency specific for our residents, the impact that microaggressions on a day-to-day basis has on their job satisfaction, on their well-being, and the incidence and prevalence. I don't think we understand it to the full extent. But we're also doing a training on a microaggression response toolkit that was developed. And I have to give a shout out to Cricket Fisher, who is a hospitalist at the Brigham and Women's Hospital, who is amazing and has done some groundbreaking work with medicine, internal medicine. And so I'm collaborating with her, and we are about to train our residents in response to microaggressions that occur. And we would like to, Dan, shout out to you. We'd love to roll this out to our faculty as well, because as we all know, we see these situations and we don't know how to respond to them real time. It's awkward, it's uncomfortable, but we need to. And that's sort of my role in this endeavor. So thank you again so much for being a part of this, for allowing me to be a part of it.
Thank you to all the panelists for taking a minute and telling us a little bit about your background. What we'll do is go forward kind of to start out with a question, and whichever panelist is interested in answering it can kind of unmute and go for it. And then in our prior mentor hour, there were occasionally people that had experiences from their own academic lives that could add to the discussion. So if you do have that, either you can privately message me, or you can kind of jump in and say, hey, I have something that I'd like to add. So please feel free to do that. The reason that we all came together is to make it an active discussion. We're very pleased to have the panelists be leading us today. So the first question that we can start with are maybe if a couple panelists, or all of you, if you're interested, could give a specific example of a challenge or a departmental request or something that you've worked on specifically that you think could maybe be transferable to our academic lives where we all are located in the country. I heard a couple examples already. I'd love to hear a little bit more detail about a couple of those.
So I can take this one. This is Nuran. And one of the things that we have been working on internally, I'm at Kaiser Permanente Rao, and I'm the residency program director here. And one of the things that we've been working on internally is trying to come up with a way to use simulation for faculty development, specifically how it applies to being supportive to everybody, basically, and to really, build in those themes from the perspective of faculty development. So I was really excited to hear about what Valerie had to say, because I think some of those microaggressions that she's talking about, I think that's what we're seeing in practice, and we would really like for there to be some kind of faculty development around this. And I think SIM is ideal because, especially from the perspective of standardized participants, you can really focus in on creating situations from which could be arguably quite complex for a faculty member to navigate. For example, I'll give you one very easy low-hanging fruit that's happened on multiple occasions. Over the last few years, we've had some of our learners, for example, that have come in and told me that a patient, for example, did not want them to evaluate them because they looked a certain way or they wore a certain kind of a garment. And, how do you approach that? And the response of different faculty to a situation like that has been basically to tell the learner, okay, just don't see the patient, I'll go see the patient and I'll deal with it. And nobody really brings it up with the patient. But I think that, you know, those are the kind of things that you really need to show support, and there has to be a conversation about it. It's not enough to just ignore it and pretend that it didn't happen and assign the resident or the student to a different patient. It needs to be addressed. And how do you empower your faculty to speak up and say something about it, because it doesn't happen automatically. This is one example of something that we're working on here in Kaiser Permanente, and exploring how to make it into an actual, you know, faculty development session.
Just to jump in on that, similar experiences at Advocate Christ, I would actually say that I actually, as a resident, was told by a patient that they didn't want to see me. And I was super surprised by this because this patient was African-American, she was female, so I naturally assumed that she would want me to be her doctor. Why wouldn't you, you know? But we all make assumptions whenever we go see patients, which is something that I have told my residents time and time again. We make assumptions as we enter that door and we see who our patient is and what their complaint is, even before that. And our patients also have assumptions of us too. So one of the things that we've been finding at Advocate Christ is that I think that almost every facility is required to do this cultural competency project or some online click-through situation that you have to do to say that, yes, I've done it, I am a good faculty member, and I have participated. Most people naturally just click through it. It means nothing to them. There's really nothing gained from that. So how do you make that into something more active? So what we've actually done here at Christ is we've created a curriculum on anti-racism through simulation. Now, this curriculum is only for our residents at this time, but we really wanted to trial it for this entire year, just to see how our residents respond to it and to make changes, you know, before making it something that the faculty is required to do, and before making it something that we have to do at all of our different sites. Because Advocate Health Aurora is not the system that I work underneath. It's not just Advocate Christ, but it's a multitude of about 27 to 30 hospitals. So if you really want something to be used standardized, you know, it has to be more standardized. So we do need a little bit more data points before we can present this more globally. But I think that these are things that we use simulation for difficult procedures. We use simulations for difficult conversations. So why can't we use simulation for conversations about anti-racism? The problem is that we ourselves are not comfortable talking about it. So I think that the very first step that you have to do is you actually have to have an open communication and an open forum to have conversations about what being anti-racist is and truly what that is before you can even start to introduce simulation, because you have to get buy-in. You can't just say, here is the simulation project, I want you to be a good doctor and to take care of these people. Of course they're going to be. Everybody's going to be a good doctor. We're all good doctors. But are you going to take anything from that if there's no information beforehand or if there's no debrief after the debrief? So you really have to have your faculty buy in. And I think that that is a really difficult thing to do. But I think unfortunately and fortunately, because of the nature of what's happening in this world today with the George Floyd's death, is that the nation and medicine is ripe for this. So we have to take advantage of what's going on nationally right now, where all of this attention is, and say, you know what, we're going to shine a light on this and improve ourselves as physicians. That's how we were able to get buy-in from our clinicians. And our clinicians actually came to us saying, hey, you use SIM to teach me how to upgrade my central line skills, right? Why can't you teach me how to be a better clinician? And we really had to discuss with ourselves where we fit to be the experts on that. You know, I can talk as a Black woman, I can talk as an African woman, but I can't talk as a gay woman because I'm not, you know, but we actually were able to reach out to many people who do identify, who are able to create what we decided to call patient identifications. And these patient identifications we embed into these simulations throughout the curriculum throughout the year to really force people to experience what it is to be somebody else and equip them to have those discussions. So I think the biggest issue is buy-in first, but you have to do work before that. And you have to be prepared to continue to do the work after that, because you can't just leave it as a simulation, unfortunately.
Thank you so much for those thoughts. And I wanted to highlight one of the things that you said, Oyen, which is that you have to have kind of a discussion before you throw your learners or your colleagues, in many cases, into a simulation about this. A lot of times we use simulation, I think, to try something that we already know how to do but might have forgotten, to highlight the need to relearn or highlight the need to practice. but this, I think, might be a different situation where some of the discussions that, at least at Rush, we're having on a fairly regular basis now, listening hours, book clubs, to try and break open this topic and really learn what words to use to talk about it. Those are kind of your departmental prerequisites, it sounds like, to then initiating a simulated situation. Now, Oyen, can you give an example of a specific way you embedded one of, or a specific patient identity that you created that could help us understand what you've done?
Yeah, absolutely. So just more on the curriculum we created. So one of my current chiefs, who is going forward to do a fellowship herself, came to me with the idea that, I want to have the discussions that we have in private and public, and I really felt what she was saying because, I knew that she had some personal struggles just with religious differences and things when she actually came into the program. And I said, the best way that we can do this is simulation. So what we actually did is that for the last 6 months, we've been going through and creating a simulation where we have patient characteristics, patient identities, and these identities are fully fleshed out. So one example would be one of the identities is an African-American female who is financially pretty well off, pretty comfortable, has a nice car. Like, you have every single detail. How old she is she married or is she single? Does she have any pets? How much money she has in a bank account? Does she have a 401k? What's in there? What type of car she drives? All these like very, very minute details to create a patient characteristic. And then we also have a brief history on what her experience has been with the healthcare system. So for this patient, for example, and you can change this patient based on whatever interaction you think that you need to fit for your residents or for your learner. And this patient in particular, we have a very difficult time dealing with patients who have sickle cell trait and disease at our hospital because we're not a sickle cell center, so there's a stigma that goes that we have with our residents, with our nurses, with our attendants in general. So this patient is a sickle cell patient who is demanded that she be transferred to UIC because they take care of her better there. Those are where her physicians are, and how do you as a clinician deal with that aspect? So there's actually 2 learners in this situation. Our residents come into the situation and we're kind of like outside of the hospital to make them feel safe. And they are given a random patient identity card, and they could be any type of patient. They have time to kind of learn who their patient is. And then they have another resident who is going to play on the physician role. And all the physician is presented with is with the chief complaint. And the moderator kind of helps move the simulation along. So you then debrief on why the resident who received this patient characteristic played this character in a certain way. So you, for example, are a white male resident and you receive an African-American female as your patient. Why did you behave in this certain way? What inner biases do you have yourself, or what in the thought processes went into why you acted this role this way? And then you also debrief with the person that played the clinician. What difficulties did you find with this patient? Why was it so difficult for you to talk to this patient? Why was it difficult for you to meet some of their social needs? And the hope of this whole project is that the more you expose residents as well as attendants to different types of patients with different backgrounds and different experiences, they can truly get to the whys. We don't really want to fix their behavior because these are things that for some of us are ingrained in us that we don't even know why we react certain ways. But we want people to start to ask themselves, why do I have this feeling whenever I see a certain patient? Why is that first gut feeling? And how do I question that and make sure that I don't let that inhibit patient care and how I care for that patient despite what my background and what my history may be? So it's a very complex thing, and we're asking our residents to do a lot, but you have to get them to buy in. So what we've done beforehand is we've done a lot of anti-racism talks. We've done a lot of, immediately after the George Floyd deaths, we actually had a moment where we just had open discussions and our residents cried, they expressed their emotions, and we talked about, some of them expressed the fear of what it was like to live in those days of rioting in Chicago and being worried about the safety of their family members. And then for some of the attendants who look like I do to say, that's every day in my skin that I can't shed, to just have those open, raw moments. And that was able to get buy-in, and then to take that and have it with your attendance. So you have to have those first opening conversations. Otherwise, people are just pretending. And the last thing you want is for people to pretend with things that are so meaningful and so serious to other people. So you really have to do a lot of education ahead of time before you throw people into simulation. Otherwise, they might not get what you want them to get out of it. Does that answer the question? Okay.
Anyone else on the panel want to comment, or we can move on to kind of an additional question that I have as well.
You know, one comment I just wanted to respond to Cheryl that had asked the group on how do you go about this, and you did a beautiful job about talking about it. And I think in our program, it's the residents who have led a lot of the discussion, the outrage, the need for this. They've really pioneered it, but we're not all coming from the same place. Generationally, we're different, right? Our backgrounds are different. We come from all over the country, the world at times in the residencies, and our experiences are very different. Awareness, we all have biases. We all have, preconceived ideas about people, even the most well-intentioned, most well-informed, we just do. We are biased by social media, by our, value system, by our families, our religion, our culture, ethnicity. So I think, Cheryl, to your point, you have to begin somewhere. And you begin with some foundation and education and listening. I think that's been brought up a lot. You listen to people's experience, and you have to build on that. And those conversations and social EM movements, and probably every single one of our programs is quite active these days in a good way. And so anyway, I just had wanted to address that, and it's difficult. These conversations are difficult, but I do think historically, having lived a long time, that for the first time people are listening, which makes me hopeful for the first time. Not lip service, not just, okay, it's an easy to solve. It's complicated historically and otherwise, but I think people are open and listening now. So, it's a good opportunity for all of us.
Can I just ask a question? I don't mean to interrupt, but is it okay? Mm-hmm. Okay, so yeah, so I put that there because literally NMA just happened in Atlanta. Cindy Price, who's on the phone, was here. And what we did, which I have to see the impact of it, is just did a walkthrough time in the history of Emory. Like literally the good, the bad, and the ugly, right? Emory was built by slaves. We didn't let a Black man in because he was Black not that long ago. We had, so in the spirit of restorative justice, right? And people still don't understand, even though it's been 400 years for Emory, it was 1834, so it's 100 plus. It was just stunning to me, and I had to reset my brain on where people are in their knowledge of history, right? I mean, those of us who live in this space, we're on it, we got it, we know it, we drink it, but it is stunning to me still, and where people are, they just don't know. So one thought is to, wherever you live, sit, breathe, you look at the historical realities surrounding the community that you're in. It's easier for me, I'm in Atlanta, right? I got the birthplace and resting place of Martin Luther King and C.T. Vivian and all these folks. So it was really an opportune moment to reset and have people rethink that and sort of be like, whoa, I didn't either know, remember, realize the impact of history on our country and in the space that you're in. So just throwing that out there as a thought. I mean, it was, once we clean it up, I'll be happy to share it with you. We did a timeline, got students involved, to your point, Valerie, who put it together. And it was real. People were like crying, they're like, man, and for Black people who are tired and fatigued, it was a sense of restorative justice to see how much they participated in the institution, and finally being recognized for that, for that hard work and that Black tax, to then be able to, hopefully, we'll see what happens. I don't have a day, we just did it. So I don't know what the impact will be, but just a thought. Thanks.
Thank you so much, and it's nice to have you, Sha.
I was just going to
Mike wanted to add in.
jump in something really quick. I think some of the comments go directly to something that I think is so central to simulation. That simulation is a safe space. Simulation is ideally an environment which is safe for the learner to make a mistake and stuff. And I think that that's why it's so important when you do stuff like this. You need to put a context, and you need to warn your providers and warn the participants about what's going to happen to a certain degree, because you're dealing with subject matter that's inherently unsafe to some people. And it harkens back to like the big debate among simulationists is, do you kill your patient? Because that is inherently like unsafe. So, and I think that's why it's really important to do to have a context, to have a representation, and to really put it in. We did this with a trans care case where we had actual involvement from a trans provider who related a personal experience, and the case was written around their personal experience and dealing with a medical provider. And we had them actually be involved in the debrief. And I think that that actually helped in many ways remove a lot of that fear for a lot of the people in the room participating and watching it. And I think it actually helped make it better. So I think that, contextualizing it and inherently recognizing that you're entering into an unsafe arena at times.
And thank you for your comment, Cassandra, about kind of the use of flipped classroom. I wonder if you would speak a little bit about some of the efforts that you've been involved in as well.
So Vidant Medical Center has actually been launching a Let's Talk About It campaign this year. It maybe made the news, so if you saw it, sorry. But it was taken a little out of context. So they had sent out some articles that they had wanted people to pre-read before they came to these sessions to talk about what has been going on in terms of social justice in our country and in healthcare and in the media. And so one of the articles they sent was some tips on how to have these bridge building conversations. And so I think that like having the information up front before they started talking about it, to some degree gave them a launching point for the conversation. I do think that when you are looking at anti-racism education, you do have to choose your resources wisely. And if you're gonna pick something that may ruffle some feathers, it should come with, I wouldn't say a caveat, but some explanation as to where you were going with that article before you just launch it out there to let people put their own spin on things. So I think the big thing with doing the simulation is going to make folks think about things and be uncomfortable is they had to be prepared to be in that space and what it is you expect of them. And so I think debriefing, we talk about it a lot after simulation cases. I think we're going to have to debrief this a little bit before we go into it so that you know what to expect. And then afterwards, talk about how it went and how you felt about it and kind of what you took from it. But I think this is very, very important in terms of like using flipped classroom for this, because I think a lot of times we just drop people into stuff, and this is not one of those times.
Thank you so much. And I agree that preparing the participants to be a part of the conversation is one of our jobs as a simulationist if we are offering a curriculum like this. Some of the challenge of a simulated case is providing an environment that still challenges your learner, but you didn't just give them all of the skills and tasks that they need to use to apply to that environment. So sometimes we try and just throw them into a situation without that pre-brief. And I wonder if any of the panelists would provide kind of an example scenario in addition to what Oyen has provided of what might you need to prepare your learner with? Is it words? Is it an understanding of their own bias by an implicit bias test? How would you prepare a learner to take part in this scenario that we're kind of talking about?
Yeah, I'll take a stab at that. So I think there are several ways to do that. There are implicit bias tests. Harvard has one that I think is very good. I've taken them, and I can tell you I do not score that well on them, and this is what I'm interested in. So we all have, like we've talked about, our unconscious biases. What's important is to bring those into the conscious light so we can then start to work on it. One of the challenges I face is that these conversations are always uncomfortable. There's always some resistance to having them. And we all are at different points. I can look back and see how I've evolved in these conversations, especially over the last few months. So my focus has always been on narrative medicine and reflective writing. I created a reflective writing curriculum with my residents a few years ago when I was a fellow. And that really pushes, I think, learners to look inward and think critically about a specific case they had. And I think this is best done when it's facilitated by a faculty member who can push that learner to a deeper level of understanding of that case. So actually, there's a case that I was really affected by a few years ago, where it was a Black woman who is actually 2 years older than I was at the time, in her early 30s, who is 10 days postpartum and had a normal vaginal delivery of twins. And so when I had seen this patient, I had come in the beginning of my shift. She was already labeled as a drug seeker for some reason and was actually about to leave the hospital. Due to several, I think, lucky circumstances, the patient ended up staying. I was able to care for her. I was able to actually get to a diagnosis that this patient had an aortic dissection. So this case, I think, greatly shaped my career. First of all, this to me wasn't who I imagined as an aortic dissection, a young woman. And then just over the years, I kept exploring this case even further. I would teach about this case. I'd often teach about it as an aortic dissection case in postpartum. And then I evolved that teaching to really focus also on racial disparities and health disparities with this case. And for me, this is just an example that when we teach about race, it's often not a case that's just about race. It's especially when we talk about racism, it's not often overt racism. It fits in other ways. And for this case, I think that patient could have easily have left and we would have never known that this was her diagnosis, that she had an emergency. So this is when we talk about narrative medicine, being able to kind of find a case like that and really go in deep into this case and talk about who that patient was, what barriers that she may have faced in healthcare that led to her getting delayed treatment. When I had seen her, she had not yet got pain medication, not even EKG was ordered, delayed diagnosis, and then even the outcome of having this diagnosis of aortic dissection. So there's just so many layers of where racism fits into her case. And I think to talk about that case and not talk about racism would just be a huge mistake. So actually in my program, I helped found our Diversity, Inclusion, Equity Committee and also GME-wide committee. And what we've tried to do is take a really holistic approach, look at our curriculum and see where we can fit in anti-racism and bring in health disparities into our curriculum. And initially this seemed like one of the most challenging things I've ever done, but over this last year, I've had so many residents who've taken a huge interest in this and faculty who I see incorporating this topic into their talks, whether it's on chest pain or cardiac arrest, whatever it is, I see them bringing in this topic. And so to me, that's really what has shown progress and to me what success looks like.
Yeah, and I just want to follow up on some of those ideas. I think Jordana made a great point. You know, there are a lot of ways to sort of start and get people onto a more level, I guess, playing field from an education standpoint to start the topic. So implicit bias, you know, you can have them read articles, videos, the reflective writing, which I love that idea. But I just want to kind of stress that one of the things is you don't want to like try and throw these all into some like 1 hour session. Like these need to be, like you can't force this. You want to leave people feeling relaxed so that they can open up. And some people may take a little bit of time and you kind of have to, you know, you can't just like be like, all right, we're going to do this. This is going to be our lecture. We're going to do one thing on implicit bias. Then we're going to read an article and we'll discuss it. Like that's going to put a lot of people, especially the people who really need it, I think that's going to put them off. They're going to feel too pressured to talk and just too uncomfortable. So just when you're designing things, kind of, you know, take take the time, make sure you, and this is maybe where it's trickier, is trying to get the time, you know, with our residency curriculums, right? Trying to get this time in. But you don't want it to feel like you've forced this time in, because you want the chance for people to relax and have a bit of an organic conversation. And that's where you really learn what people need, especially, which I think is really important, because we've started doing this with town hall meetings, essentially town hall meetings within our department. And when you give them the time, that's when you really hear some interesting, like, oh, okay, like people start to open up and you learn the differences in what people may need, which is not necessarily because what you were thinking of. So just take your time with it.
I think a really important thing is that you really have to get buy-in. And one of the ways that you allow people or you create buy-in is that you have to make it important to them as an individual. There's a lot of people who are naturally interested in these topics. We're all on this conversation. I don't have to convince any of you that this is important. You know, I don't have to tell you how important it is to be anti-racist as a physician. But some people, they've never thought of that. And you actually have to come from a place where you can't judge them because of the fact that they've never thought of it, or because they've never thought, how interesting is it that I must make sure that all of my patients, whether they look like me or not, can understand me, and that I can communicate with them in a way to put their best interest in, you know, up front. So I think that creating buy-in by making it important and pointing out the things that they might miss. For example, you could miss an aortic dissection if you have labeled a patient as pain-seeking because of whatever reasons you've labeled them as such. And even if it turns out to be, hey, I've labeled them this way and it has to do with something being racist. And then you have to ask yourself, hey, as an individual, have you created enough buy-in in all of your individual learners? Because until you do, until you make this topic important enough to them to where they're going to think of it as worthy to learn, it's not going to be as easy for them to get anything out of as it is to get a skill set that they have to do. You have to know how to put a central line in, but you have to know how to talk to a trans patient. I say you do, but now I need to tell you why you say you do as well, and what effects that could have downstream, how that can affect you downstream, if you miss something downstream, if something happens with that patient's health. So you have to bring it back to your physician first, your clinician first, whether you understand who this person is or not. That's not your job to understand who that person is. Your job is to provide the best care that you can. And if understanding who that person is allows you to provide that best care, then we need to get you there. But you have to create that buy-in first. It's very easy with residents, especially residents these days, because they are thirsty for it. Like, we actually have an ongoing anti-racism curriculum that has been going on for the last 4 years that our residents have fully bought in on. And the way we kind of lured attendance in on it is we do a book club. You know, you read a book and then you come hang out on the hospital's dime, you drink, you eat, you have a good time, you have these discussions, right? So the buy-in is, hey, it's a social hour, right? But then we're also going to talk about some really important topics when you've let your guard down because we've given you a couple of drinks. Just kidding. But you know, you're more comfortable. It's more of a social situation. And that way you can actually get people to have those true conversations, because you don't want people to pretend to be who they're not. You want them to bring their true selves, because that's how you start to work on that. And I bring my true self. And there's a lot of things I found out about myself also, even more so that those implicit bias tests have told me. But there's a lot of things I need to work on also. And to know that as a panelist or as a debriefer that you too have room for improvement is also very humbling, and we all just kind of learn together.
Thank you so much, Oyen, and to the other commenters so far. There's a question raised, and there's some discussion in the chat about how the current environment frames these discussions now, which is maybe different than before. And hopefully I summarized that well enough. Cassandra and Mike both have offered responses to that. So I wanted to give you a chance to speak, because we are actually coming up on the hour when we were hoping to finish up. So if either of you would start, that would be great.
I think it's a great question. I mean, and not as an inherent plug to SAEM, but as an inherent plug to any major academic organization that's national. If you can do this in a framework of an organization, that helps you get more buy-in, especially with your senior leadership in any department that you're going to be in. The other thing that Cassandra pointed out, and I think it's a great point. I mean, a lot of this discussion is being driven by the young kids, I get to say now. since I'm officially a cis old white male. But, you know, I think it's being driven by the students. And, you know, we, right after George Floyd's death, the White Coats for Black Lives, with the support of my hospital, and Children's National is not a particularly radical institution, they staged a moment of silence outside the hospital that was sanctioned by the CEO of the hospital. So I think there's two ways to buy in. If you have an academic organization that will back you, that's great. Otherwise, get the students and the residents to push for it, because if they're pushing for it, the leadership has to listen to them.
I think it's helped a lot, like in terms of pushing the envelope into what the actual clinical learning environment looks like. Our GME office has actually convened a GME Diversity Inclusion Committee to specifically look at the policies of our GME and of our institution to see how we can make those more equitable and more inclusionary across the board, which I'm not sure if we would have had as much of a push for it prior to all of these things happening, but we have the buy-in from the CMO of the hospital and several of the senior vice presidents. And so like having all of those people on board really does help you make change in the institution, which has nothing to do with simulation. I recognize that. But I do think that having these conversations is hard, and simulation helps us learn how to have those difficult conversations in a safe space.
So I have a question related to that. Would it be better to have learners who, you know, admit or recognize their limitations in background knowledge, to kind of give them a simulation which is almost like a softball, an easy thing to try and talk about first? Is that where we should be going with this, to have the easier discussions in our simulations and then the harder discussions in our debrief? How should we, as simulation people, be starting to incorporate a lot of the things that we've been talking about? That's one of the challenges, and some of you have kind of worked on that already.
I'm going to answer this quite honestly. I think all of these conversations make us all very uncomfortable. I don't love to talk about this every single day of my life, even though I'm more comfortable than others. I think that for far too long, and maybe this is just the generation I'm in, we have allowed our own personal discomfort to prevent us from having important conversations, and therefore things have not changed. So I do not force any of my residents to participate in any of these conversations. No, I do not. But I do strongly advocate that they attend at least. They don't have to participate. They don't have to talk. Sometimes you can simply learn just by being in the present and just by listening. And maybe the next time another conversation like this happens, or another simulation like this happens, you will be more comfortable in having a conversation. But you're not forced to participate in any shape that you're uncomfortable with doing so. The other thing is that we also really want to protect our residents and their learning. And we don't want any resident to look at somebody like, well, I always knew you were racist, so now you've confirmed for me that you're a racist by the things that you said. That's not what we want. And we don't want people to not speak to, oh, I don't want people to think that I'm racist, whereas I don't know any better and I'm just asking a question to learn. So I do allow my residents to email me anonymously, or they just like drop off messages in my locker of things that they want me to bring up, and I will fully bring them up as in whatever context. And if it is a conversation that we end up having, great. If it just stops there, then it just stops there, but at least it's been brought up and it's food for thought. I think that we do our residents and our learners a great disservice by trying to protect them too much, because this world doesn't protect us. So why would we protect our learners who are supposed to take care of these people in this world?
All right, we are close to time for this conversation. We did advertise as a mentor hour, so we'd like to respect everyone's time. One thing that we'd like to share with everyone on the call and everyone in moving forward would be some resources. And some of the panelists have provided me with some links and literature and things that we can publish Snezana has made us a site within the SAEM site, and I believe it's under the meetings tab since this is a webinar virtual meeting. That will be available within the next week. There will be a recording if you'd like to review that of this discussion, and then also some resources that we are able to use to continue to educate ourselves and continue to learn about this. Perhaps I can also have the contact information of the panelists, or at least, Snezana's contact information, so she can connect anyone that would like to speak with them further over the course of the next couple of weeks. We have time for 1 or 2 more questions or comments if anybody would like to add something to what we've already discussed.
Sarah, can I ask the question about the implicit bias? I don't know if some of the panelists saw that, or is that too long for the end?
Go for it.
All right, so thank you all for taking the time. It's been very insightful. I put the question, if you're able to see it on the chat, my question was in regards to, in academia, it feels as if it's more comfortable to focus on implicit, or calling it, unconscious biases, when the reality is, which is why I think sometimes these tests don't feel as truthful to individuals who take them. And it's, I think, some of the commentary sorry, I'm forgetting the correct word. But do you feel that it's really a personal bias and prejudice that because of our privileges, we didn't have to acknowledge sooner?
So I just wanted to clarify. So you're saying that instead of labeling it as implicit biases, that maybe it is our privileges that has prevented us from labeling it what it truly is.
Yeah, that's actually not. Yeah, that's not actually as unconscious as we would like to believe it to be.
Gotcha. I'm going to be honest. I think that everyone has their own stuff that they come in. And the word I want to use is not stuff, but I will, because this is a professional environment. But everyone has their own thoughts. Even if you are somebody in a marginalized society, you also have your own biases. I think that it's almost unfair to say my bias is less than yours because I've been through more than you have. And I think that when it all comes down to it, even on this conversation, we all have our own privileges. I am privileged because I am a cisgendered female, compared to somebody who's a transgendered female. And I think that once we recognize our own privileges as it has to do with other individuals, I think that it actually humbles us in a point where you can then approach these things and not in a space of attacking, because you always have to remember that everyone is a product of their environment, their history, their parents, their grandparents, and everything else that contributed to who they are. So they did not choose to be who they are today, but they were sculpted into who they are today. So now you have to unsculpt that, and you have to tell them that who you are is not necessarily the best version of yourself. And I am saying that even though I am not necessarily the best version of myself. So I think that my approach has been, you know what? I say some crazy stuff too. You know what I'm saying? I have my own issues and I have my own biases that I need to check on a regular. And I probably should stop using certain terms as well. I am also a work in progress, as are you. How can we be a work in progress together? So instead of labeling you as you are racist, because that is the quickest way to shut someone down, or you are homophobic, or you are anti-trans, or you are anti-female, you are, we don't really get anywhere with that. It's like, okay, you have your issues, I have my issues. How can you help me with mine, and how can I help you with yours? And we come from a place of learning and genuinely wanting to change, as opposed to wanting to change the other person and place blame.
Yeah, and I know I'll also comment, thank you, that was wonderfully stated. About our privilege. Privilege is something I thought this was a beautiful statement, and an aha moment for me is something you don't realize that you have. right? A privilege when I can walk into a door or a store or something, I don't see my privilege. It's invisible to the person who has privilege. And an awareness of that to me was profound and prophetic, that someone doesn't follow me around a store or assume that I'm shoplifting, or they walk across the street from me, or they have certain, or they, you know, or they have biases about the way I look, my height, my race, my gender. So you just aren't aware of it, and we all have them. And I think this is part of this open conversation about privilege. And you're right, some of it's obvious and some of the bias is real and not so implicit. Some aggressions aren't microaggressions, they're macro, and they're awful and they happen. We talk about micro, but some are really so offensive, and so there's a spectrum of this. And what to do about it is sort of to understand people come from all spheres and are on all different levels of their understanding, of their ability to digest this, to work on this, to understand it. So again, I think thinking about it in that way, privilege is that way. For me, like, wow, I just didn't even understand how much in what areas and what arenas I had until somebody said that to me. So a little grace for everybody, allowing them to get where they need to be is helpful. And ignorance, just because you don't know any better, or you weren't you didn't grow up with a certain value system to understand and respect others, I think it's really important. And we're all here trying to deal with this and try to understand it and try to all be better at it and help our residents, our faculty, with the reality of bias, implicit, microaggressions, macroaggressions, and trying to be good clinicians to take good care of our patients in the best way we can.
Yeah, I know Cheryl, I think, is not on anymore, but something I've learned from her, I know a lot of us have been mentored by her and follow all her work, but it really, the teaching that we do always needs to come from a place of compassion and love. And I think that's echoing what many of us are saying on this panel. For me, this topic has always been one of the hardest things to teach out of everything I've taught. I probably lose sleep over the way I run discussions, because to be really effective, you need to first work on making sure everyone feels included and feels that they can participate and be a part of these conversations.
I think part of having grace like also involves recognizing that the other person is not coming from the same place that you are. And so I wrote in the comments that like sometimes what seems like a macroaggression to one of us is not a macroaggression to the person who said it, because they didn't realize like how that was going to be taken. And so I think making sure that you give not only some grace, but an understanding that they don't have the same perspective that you do, and coming at it from that area, I think also changes how you frame the discussion and how you start the discussion, more so than that was the wrong thing to do. It's more of a, hey, why did you say that? To maybe draw the discussion out in a little, I don't really want to say aggressive, but something along those lines kind of manner.
I think you raised it, and Naran raised it in the comments. It's if you approach it from a perspective of curiosity, you know, why would you do that? I mean, because sometimes, I mean, lots of racism or things that are perceived of racism are actually classism, and we can look at comments about rednecks and white trash and stuff like that, and that is implicitly classist behavior to describe poor white people, and so that carries over into the Black community and the Latino community. And, so many of these conversations where people might say something and they're not actually being racist, they're being classist. And, if you don't actually get to the point of that, you're not getting to their fundamental bias. So I think that, for simulationists, all of us are certainly, we get exposed to the idea that you should ask questions with curiosity as a means of getting to an answer. And I think that's kind of I think that Naran's point about that is a really great way to look at it.
All right, thank you to everyone and for all the excellent questions, excellent responses, for giving some tools for us to hopefully use as we go forward. we do have to wrap up because we're edging on the edge of an hour a little bit more. So thank you to everyone for being here. And check the chat if you would like the contact information for any of the panelists. It is over there. So I'll leave this up for just a little bit once we conclude. And I really appreciate you all being here. Watch out for the next in the series. From the Simulation Academy, we'll be talking about how to use your simulation experiences academically to go up for promotion and to prepare to go up for promotion. So that is kind of the next thing in line for the Simulation Academy. We also have the ongoing collaboration between ADIM and simulation to work to build a curriculum. So if you're interested in jumping on that, I guess contact me and I'll put you in contact with the right people. So thank you so much, everyone. We'll wrap up.
Thank you.
Thank you.
Bye. Thank you so much.
Thank you, everyone.
Thank you, everybody.
Thank you.
Bye.
Thanks a lot.